And this is the reality for a lot of my clients, that they are going to have a stronger epidural because I know the hospital they're going into, they're telling me that that's what they're going to do, but they're still saying, but even with that epidural, are there things I can do? And I'm like, there's always something you can do. No matter what thing has laid down, you still always have options. You always have options.
Yeah. Welcome to the podcast. I'm Tracy Donegan. Today I'm speaking with Dr. Sinead DuFour, based out of Canada. Dr. DuFour teaches and conducts research in the Schools of Medicine, Nursing and Rehabilitation Science and is an associate clinical professor. Join me today as we discuss the importance of women's pelvic floor health throughout our reproductive lives, not just during and after pregnancy. Now I bring you Dr. Sinead DuFour.
Hi, everybody. Welcome to my next podcast episode with the wonderful Dr. Sinead DuFour, who is an absolute expert on all things pelvic floor related and pelvic related, and as regards to women's health. And I've had the pleasure of working with Sinead on a couple of projects, and hopefully we'll have more opportunities to work together in the future. But welcome, Sinead. Thank you so much for taking the time out of, I know is a busy time of the year for you, but tell me a little bit about how you found yourself in this position, literally. Like, did you grow up wanting to go into women's health, or
Yeah,
tell
thanks
us?
so much, Tracy, for having me. And I think that's a great place to start. So, I'm an academic clinician. So, I kind of spend half my time in the academic world teaching and conducting research, and then half my time as a clinician, as a pelvic health physiotherapist. And since I was about 13, I knew I wanted to be a physiotherapist. I had unfortunately been hit by a car and had to go through a lot of rehab. So I knew I wanted to do that, but it really wasn't until I was pregnant myself with twins that this whole area of pelvic health and perinatal care, and quite frankly, some of the problems with the care really emerged. So, in fact, I was a good way through my PhD when I got pregnant with twins. And so my PhD actually, funny enough, it has nothing to do with pelvic health or perinatal care, but very much has to do with healthcare system design and empowering people to self-manage better. So it's interesting. Those are pieces I really actually bring into my care. But through really my own experience, I developed quite a passion for this area. And the timing was interesting, actually, because I'm in Canada. I'm in Ontario, in Canada. And in Ontario, it's only been for about a decade that sort of this area, the specialty area for physiotherapists has been recognized. So in 2012 is when sort of our regulating body for physiotherapists, the College of Physiotherapists of Ontario, sort of reorganized some of the constituents with how PTs could practice, allowing sort of just additional specializations or special tasks that people could develop competency and then be rostered in a different category. And, this area of pelvic health, and specifically, having competency to do internal exams to be able to assess the internal pelvic floor structures in the pelvic floor was one of them. So I really quite frankly found myself, I had just had my babies, just finished my PhD, and then this changed. And I felt so passionate and called to kind of do all the extra training to then start to do this. So that's really kind of how I've landed. So it's very much now been for about over a decade. This has very much been my area of expertise clinically, and now even from an academic perspective.
Fantastic. And it's so interesting that you really did have a good idea of what you wanted to do when when you grew up at 13. It's amazing. So just you touched on the subject of internal examinations. So just for someone who's watching or listening and they are pregnant, should they be seeing a women's pelvic health specialist now if they're having a perfectly normal pregnancy, have had no problems with bladder leakage? Is this something that every woman should be doing as part of routine antenatal care?
Yeah. So, I mean, in fairness, even if you asked me this question, Tracy, 5 years ago, I would be saying, yes, there is so much good that can come out of that one visit. And I'll go into that in a little bit more detail in a moment. But at this point now, my academic side can really confidently substantiate that recommendation because we have the most recent NICE guidelines from 2021 actually does recommend from the perspective of prevention that
Mm,
absolutely every single woman when they're pregnant that that's a really excellent opportunity to honestly learn a little bit more about their pelvis and their pelvic floor and these structures. Unfortunately, this is a part of the body that, females actually don't understand very well. There has been a lot of sort of shame associated with some of the functions of this part of the body. And we really kind of get to this point in our life that we are quite ignorant, right? And so,
mm,
the NICE guidelines, of course, actually acknowledge, quite frankly, adolescent females should be learning more about this so they understand, their infradian cycle. So they understand that. They understand why, in some cases, they might be having pain and what might be going on in their biology and how might they be able to support that and normalize it, right? So, really, I mean, this educational bit should honestly happen earlier, but the data is so clear around this perinatal care period that we have such clear established risk factors for injury and dysfunction to the pelvic floor. And there's so many things we can actually do to prevent that. An ounce of prevention is worth a pound of cure. So I would say very strongly that so much good can come if you are pregnant, even if you just want to engage with a physiotherapist who has this extra expertise just one time, even if it isn't even in person, Tracy, really and truly. So half my practice now is virtual.
okay.
So, of course, in person, I do an actual physical exam, including an internal exam of the pelvic floor. But half my practice is now virtual because I sort of see people from all around the world. And I would argue you can get about 80% of the benefit in terms of understanding, how you might prevent an issue, understanding how you can kind of empower yourself for a great birth. We can get about 80% of what's relevant in terms of education and really inspiring and motivating people through a virtual visit as well, because there are people who just quite frankly aren't interested in an internal exam. And that's okay. I mean, there's an extra bit of benefit that can come from that for sure. But there's a good bit we can do even without that when you are seeing someone who has cultivated, the expertise in that area.
That's fascinating. So, because when in my work working with women as well, there is a sometimes a reluctance. And I think again, this is around the lack of research, women's health research, and that body shaming aspect of that they're quite nervous about going to see a women's health physio
Mhm.
because or they're putting it off because of the I'm going to have an internal examination, and immediately they're thinking especially if this is post labor, that if they've had a difficult labor, or if someone has a medical condition or has had a history of trauma, that might not want to have that that physical examination. So I think the fact that so much of this can actually be done virtually or without the
Mhm.
examination, I think will be reassuring for I think for a lot of women that it's not a requirement, but there are
Mhm.
benefits to having that. And tell me, so what when you're doing an internal examination, and let's say
Mhm.
it's postpartum, what are you looking for?
Yeah, so this is a great question, because you're quite right. The pelvic floor is a place that sort of holds so much fear, right? So even people being like fearful to even have a healthcare provider kind of go into that area. And some of that I think is because there's a lot of mystery and people don't understand it. So they're sort of scared, right? But because the pelvic floor,
Yeah.
ironically, is a place that holds a lot of fear, oftentimes that's the very reason why we need to understand that, because as soon as the
Mm,
structure is holding fear, it actually holds a lot of tension. And then this doesn't actually even allow the structure to work particularly well. So that is a really good point, but we can get around a lot of that honestly without even doing an in-person exam. And honestly, COVID taught us a lot about that because all of us had to switch to virtual care for a while. But what would I do when I do actually see someone in person? So I'm trying to do a couple of things. So one of the things is I'm trying to actually help that individual who likely has maybe a bit of fear even seeing me as a practitioner, but also probably has a lot of fear and worry about what happened to them through their birth. And so I'm almost
Yeah.
expecting a little bit of a protective mechanism to be present in the pelvic floor. And one of the ways that we can kind of instill a sort of sense of safety back into the body actually is through proprioceptive input that's safe. And these different inputs, there's lots of different ways to do it. But that's part of my purpose is hopefully providing a really safe space at the womb where I practice, where a woman can come in, and really how I conduct my exam is very different generally than the way they're used to having it, an internal exam. So I'm always actually sitting right beside them. I'm not sort of at the end of the bed. I don't have their legs in stirrups. I have their legs just in a very neutral kind of bent position. I have them draped really, really well. And I'm really kind of going very, very gently, explaining to them all along the way exactly what I'm looking for, exactly what I'm doing.
Hey there, if you're enjoying this conversation and are passionate about evidence based care in labour, the best way to support our work is to subscribe and share this episode with other amazing women in your life. Your support is so important to us and helps us reach more mothers with empowering content. So go ahead, hit that subscribe button and spread the love.
So I think sometimes even that, like having someone engage with them in this really gentle, safe way. And then I'm talking them through. So the first thing oftentimes I'm just checking for is, does it sort of seem like there's any obvious sort of soft tissue healing that hasn't, completely occurred that might preclude me from doing the exam in the first place? So I'm taking a quick look. Does it look like there's any stitches that haven't quite come together? Does it look like, just to make sure it's appropriate to do that exam? And then, as long as everything looks appropriate, I would go ahead and start. I usually kind of honestly just use like one gloved finger um, going into the vaginal canal, but that's actually how we can get sort of a sense of what the pelvic floor along the bottom is doing. So I'm quite literally feeling for how much muscle tone is there. Are there
Mm.
areas of tissue that are kind of quite bumpy and they just don't seem like they're healing as well as we might want them to? And a lot of the times, if that tissue is in this tight, tight position, its pumping action, its subpump action is compromised. So it's not going to heal as well. If mamas
Mm.
aren't really breathing through their diaphragm through this postpartum period, and sometimes they're depleted, breastfeeding's not going well, like they're really, really tense, that lack
Mm.
of oxygen perfusion, they're not going to heal as well. So I'm looking for some of those features. I'm looking to see if when they actually in their brain are trying to lift and contract their pelvic floor, are they finding those muscles correctly, doing it correctly? Are they able to release them? Right? So I'm looking for all of these different parameters. Honestly, this exam is quite quick. If you're going to someone skilled, it's typically very gentle and it only takes a few minutes and it can give us a lot of information. And then it's an opportunity too for me to help that person connect a bit with their pelvic floor. If there's particular areas of the pelvic floor that are really holding tension, I can kind of have my hand there and just ask the woman, you can feel my hand here. Can you feel like, does it feel a bit uncomfortable? Because usually tense muscles are tender on palpation. And
Mm.
they'll say, yeah, that's a little bit sore. And I'll say, okay, are you able to tell that part of your body to let go a little bit? Right? Imagine it's like in a
Mm.
fist. Or is your brain able to tell it to let go? And they'll do that. And then all of a sudden, I'll feel that tissue melt right under my hands. And I'll ask them, I'll say, does that feel different? They say, yeah, that feels so much better. And I'll help them to be able to connect that sometimes the uncomfortable feeling they're feeling actually is just that. And they have a lot of power to kind of let that go again. So there can be a lot of good that can come from literally just that few minute type of exam. It's also going to be important for individualizing pelvic floor muscle training and really seeing what that person's body is able to do and where the deficits would be. But as I said, even through virtual, I can kind of guide someone to do a little bit of external palpation on the structures where the pelvic floor attaches. And, we can kind of garner some sort of benefit and a little bit of feedback that way.
Yeah, I think it's interesting as we are seeing kind of changes in women's health these days, and women wanting to do their own pap smears. And so I think there's yeah, definitely so much opportunity there for supporting women again who don't have access to you being in Canada,
Hmm.
or don't want to have that physical interaction. But I guess, again, we're back to, being able to explore our own bodies and understand our
Hmm.
own body with someone even talking us through it. What am I looking for? And that, because as you know, and I'm sure you've experienced this in your work as well, that we'll come across women who've actually never put a mirror
Hmm.
to their reproductive organs. They don't know what their vulva looks like. They may not have even, themselves touched inside their own vagina. So
Hmm.
I think I think there's so much benefit to having, an expert do this, but I think there's huge benefit for as well for teaching women to
Hmm.
get comfortable with your own body. So you do, as get older, you are aware of changes in your body, because as I'm always saying, we tend to live from the neck up, and we really don't
Hmm.
recognize something is off in our body until
Hmm.
something has gone wrong, until we're in trouble. But I just have a question for you on, so, you go on any social media account when it comes to pregnancy and birth, and you'll see lots of talk about do your Kegels, and you need a strong pelvic floor. So I know
Hmm.
we've talked about this before, and we have some recordings in the Gentle Birth app around,
Hmm.
not just about the strength, it's being able to relax it. Can you talk a little bit about some of the myths out there about training the pelvic floor, what you're supposed to
Hmm.
do, and really what you're looking for, to optimize those muscles?
Absolutely. So this is a great place for us to, I think, shed some light on, Tracy. So you're quite right. Like the actual recommendation from the various clinical practice guidelines supports the use of individualized pelvic floor muscle training antenatally for both to correct symptoms if you have them when you're pregnant, but also for prevention. So we have guidelines for this. Many people in their mind think pelvic floor muscle training means a protocol that aligns with what traditionally Dr. Arnold Kegel set out, which is a strengthening protocol. And that is actually not what it means at all. Individualized pelvic floor muscle training means that it means thinking about the individual in front of you, garnering their individual uniqueness through some type of assessment, either virtually or in person, to figure out for them what would be an appropriate way for their pelvic floor to develop optimal fitness capacity, which means it has to have full range of motion and full length. It means it has to have proper coordination. It means the automaticity function is there. It means it has reasonable endurance as well as strength. And so, if really a person didn't have any deficits on the strength side, but actually they are more prone to these protective mechanisms, the automaticity isn't there. It will do them no good and actually probably make them worse to have them do a protocol that's focused on strengthening, like traditional Kegels, where it's a max contraction and the emphasis is on the contraction of your pelvic floor, holding that for 6 to 8 seconds and repeating it, right? So that's kind of where we're at. We need to make sure that people have exercise is always tailored to them, and that includes the pelvic floor. And so, what we find actually is a much higher proportion of people when they're pregnant, going back to what I said before, actually have more of these protective mechanisms in place. There is a lot of fear around birth. There is a lot of fear actually around aches and pains people feel in their pelvic region when they're pregnant, because there's this awful narrative out there that your pregnancy hormones make your pelvis unstable and that's why you're having some discomfort in that region, which is completely false. And so then people get fearful of that. And so really we see lots of layered reasons why, for the most part, people actually really need to think a little bit more about understanding what their pelvic floor is doing so they actually know how to let it go and how to actually make sure they understand how to coordinate it gently with their breathing diaphragm. Like as we inhale, our diaphragm kind of drops down and expands out, and our pelvic floor follows suit. Our pelvic floor actually follows the diaphragm. And so, if we're breathing well and we're in a reasonable postural alignment, that we have good connection between the diaphragm and the pelvic floor, that pelvic floor is almost going to get a little bit of gentle conditioning on its own. And so we want to make sure that this buddying function is there. We want to make sure if people have these protective pelvic floors, we actually give them other lengthening strategies. If we think that, we actually do have to develop a little bit more on the contractility side, things just aren't contracting well, they are a little bit weaker, then we would want to kind of add some of that in. And, so it's very individualized. And I think you're right. There still is this notion that, a healthy pelvic floor is a strong pelvic floor, and a strong pelvic floor actually means a tight pelvic floor, and the tighter the better. This whole concept of like a husband stitch after you've birthed your baby. I mean, tighter is not better. We always want full length, full range of motion for optimal function. So, yes, just to myth bust around that, it's another reason why really people should be getting guidance. They shouldn't just be jumping onto some random unsubstantiated like website or social media handle and, following that. We really need to make sure the advice you're following is from someone who is going to give you good evidence-based guidance.
I just jump back to while we're myth busting, you mentioned about the idea around pelvic girdle pain and that it's
Mhm.
caused by pregnancy hormones, because that's a big one
Yes.
that's out there, that relaxin causes all these problems. Can you talk to that a little bit? Because that would be a great myth to bust, I think.
Yes, absolutely. So, as you know, Tracy, this is, probably one of like my biggest soapboxes. Um, But yes, really and truly, this is an area that I have published extensively on. I've researched it, but it's a huge part of my caseload from women all around the world who end up with this very debilitating pelvic girdle pain, either when they're pregnant and in many cases because they were misguided, about what the pain really was all about, then it
Mm.
ends up lingering on and on and on in the postpartum period. And so, what we know now conclusively, we know that, of course, hormones are relevant. I mean, hormones are always going to be relevant when it comes to function and how muscles work, and when it comes to sort of sensitivity in the system, right? But they're not relevant how we thought. We used to think, and frankly, it was a plausible theory, right? We have relaxin,
Yeah.
it relaxes the tissues. Surely this too much movement must be the reason. But we can bust that really quickly. I mean, we have extensive studies that have busted that, even a systematic review that shows that relaxin has no correlation. But even if we think, but not every single mama has this issue, they don't. Not every single
Hmm.
mama has this issue in all of her pregnancies, right? So right away, we're like,
Mm.
okay, the pregnancy's not the problem. Our bodies were designed for this. It's the context around the pregnancy. And this is why we see this oftentimes in the second or third pregnancy. The established risk factors for this pain presentation, and it makes a lot of sense actually when you understand how the biological systems work. But the established risk factors are one, having a previous birth. Well, we know that a first time birth, there's a high degree of trauma associated with that. Another independent risk factor is a previous trauma. Another independent risk factor is smoking. Another independent risk
Mm.
factor is dissatisfaction with work. Another independent risk factor is lack of belief of improvement. And so these are all,
Mm.
none of these are mechanical factors. These are all
Yeah.
more physiological factors. And so, the lack of belief of improvement is important because when we have this narrative that this is related to the pregnancy hormones, therefore this is an issue that's going to track with the pregnancy. So it's just going to get worse.
Mm.
We will do our best to palliate it until you birth your baby. And of course it goes away. Like this is the narrative and it's so wrong.
Mm.
And it's actually feeding into one of the risk factors, your lack of belief that it's going to improve. And so, one of the things that you can maybe provide in your show notes, Tracy, is the infographic that myself and other Canadian physiotherapists recently published in the
Right.
British Medical Journal. That really is a summary of like the state of the updated science with all the
Right.
different things that people can think about and actually do to self-manage and really understand this issue for what it actually is.
Fantastic. Thank you. We will definitely include those in the show notes. Can I quickly move on to labor and birth and the
Hmm.
pelvic floor? So I think you have similar circumstances in Canada as we see here in the US and a lot of the Western world when it comes to positions that support the pelvic floor in labor, especially when it comes to the second stage. So are you
Hmm.
also seeing in Canada lots of women in on their backs or in stirrups and not in optimal positions to support the pelvic floor and birth in itself?
Absolutely.
So are you seeing the same thing and the coached pushing and hmm,
Yes. So we do. And it's frustrating. In fairness, it's one of the wonderful things about the practice that I work at, the womb, the world of my baby, because really like our whole team, including our doulas and our midwives and, our whole team, we all are aligned in terms of, well, one, quite frankly, again, this is like the academic in me, but the best practice guidelines actually indicate recommendations very, very, very clearly that line up with, what makes sense with the mechanics of the pelvis, from the perspective of a physiotherapist, and also generally what women disclose to us is their preference. So all those tend to line up. And, and then
mm,
people kind of enter into this, public system hospital complex, and decisions, unfortunately, are made for reasons other than what do the best practice guidelines say? What does, this woman's preference? Like, care decisions are made for other reasons, unfortunately. And it's a bit of a problem. One thing I will say, if I reflect on my last 10 years of practice, I do see things getting better. That having been
good.
said, I'm also probably have a bit of a biased sample because I mean, I'm getting sort of, the reflections of the clients who have actually had the womb as support. So they are going to be the ones that are more likely to understand that the best practice guidelines say there's a lot of benefits to not being on your back. They're going to be the ones who most likely understand that when your hips are in external rotation, that's narrowing the pelvic outlet. They're going to be the ones that understand that when you close your glottis and hold your breath to push, through sphincter law, you're closing your pelvic floor. So, yes, you will generate a lot more power. It's a weightlifting strategy, but you are now blasting a lot of force through a locked door so we can predict injury, right? So, we're going to have clients who are going to be more likely to understand that. So then it's probably not a surprise that they're really advocating. They've done their homework, they're
Mm,
prepared, and their births go differently, right? But I must say, like, I have seen things improve over time, but I recognize I have a bit of probably a bias there. I think there
yeah.
is so much room for improvement. It's frustrating to me as someone who I've worked very closely with the Society of Obstetricians and Gynecologists for the past about sort of 8 years, sitting on some of their committees. I've led some of their clinical practice guidelines. And it's incredible how much resources are putting into these committees and these beautiful guidelines that are incredibly rigorous. And they go out, but then there's nothing done in the Canadian system to actually help our hospitals implement them. And so,
Mm,
like, it's frustrating. Like, it's very well established what we should do, what would prevent pelvic floor trauma. It's well established. It just isn't implemented particularly well. And that's why, really, it's
yeah.
almost like, and I know you and I, Tracy, we've kind of come to this conclusion we have to get right to the mama and make sure
Yeah.
they
Hmm.
understand what they need to do to use their voice and be prepared because they do have the deck against them a little bit the way our systems are structured. And I know we've talked about that before.
Yeah, it's definitely I would say anyone who's going into kind of the system to give birth, really you have to self-advocate. And if you're waiting
Mhm.
on the latest and greatest evidence to find its way into clinical practice, I thought and I joke about this, but don't joke about it. Your kids will probably likely on their way into college before those guidelines are implemented. So I think it's like
Totally.
17 years or something is the average.
Totally.
So yeah, self advocacy and understanding the physiology of birth and
Mhm.
and understanding why it's so damaging to follow this Valsalva maneuver, that
Yes.
weightlifting maneuver of the holding the
Yes.
breath, it affects the whole woman's physiology, so
Hmm.
it's affecting her cardiac output. It is, which of course is then going to affect blood flow to the uterus, and how well
Hmm.
that's working. So what would you say to someone who is due to give birth in a couple of days and maybe has this is the first time that they've heard this? What would you tell them about how to push in labor? They're at that
Yeah.
second
So,
stage and they're feeling the urge.
yeah. So, what I would say is really and truly, I mean, the guidelines are pretty clear that, spontaneous pushing. So, if you, as the birthing mama, are really following your own instincts and you're following your own body's wisdom and intuition and you're trusting it and following it, that seems to fare the best for the pelvic floor and frankly a whole bunch of other things, birth satisfaction, etc. So I'd be saying, when at all possible, if you can be in a state that you can have like an awareness of these urges and sensations, and if
Mm-hmm.
you're, opting for something like an epidural, if it can just be like a lower dose, so you're not suffering, but you haven't cut off all those connections, I would say that's ideal. If we're in a scenario where, and this is the reality for a lot of my clients, that they are going to have a stronger epidural because I know the hospital they're going into, they're telling me that that's what they're going to do, but they're still saying, but even with that epidural, are there things I can do? And I'm like, there's always something you can do. No matter what thing has laid down, you still always have options. You always have
Yeah.
options. So I'm saying, so even in those scenarios, you know, with a stronger epidural, you might not be able to be birthing on hands and knees or high kneeling,
Mm.
which in ways is probably the most optimal to really get the pelvic outlet, as wide as possible. So there's this least resistance for babes to come out.
Mm-hmm.
But you can be in side lying. Side lying's a beautiful position to protect the pelvic floor, particularly if you're side lying with the top leg kind of a little bit more in flexion and the knee kind of drop down. So the hips in a little bit of external rotation. And then your birth provider would kind of almost be in behind you. That's a great
Mm.
option. That's really available to you when you birth. If for whatever reason you end up on your back for a variety of reasons, I really make sure the mamas I work with know that like not all is lost, and don't be thinking, uh-oh, now I'm in the worst position, because like that's just not helpful to be thinking
Yeah.
about in your birth. You still have an
Mm-hmm.
option. So you still can make sure that you have sort of just in around your sacrum bolstered up a little bit with a towel. So there's a bit of room for the tailbone and sacrum to extend, so we can still extend that pelvic outlet, and try to make sure your hips don't go in external rotation. Just keep them in neutral. So I
Mm.
sort of walk my clients honestly through all the options. And then with the pushing part, understand sphincter law. Try to keep the back of your throat open. The more
Mm.
sort of almost like lower tone, like sounds you can make, we see that really correlates with just better sort of tone, honestly, in that vagal nerve and just better function and opening of the pelvic floor. So it's kind of thinking of like sphincter law, thinking of like the mechanics and the positioning. And at the end of the day, thinking of a position they kind of feel safe in and powerful in. I have had some clients actually who have had home births and whatnot. And in the end, when they've come to see me 4 weeks after their birth, to say, you know what, it's the darndest thing. We went through all that stuff. But in the end, I actually felt just stronger and more powerful lying on my back. Now, they'll say, granted, I used your tip about the towel, and I definitely had my legs more neutral because I was kind of almost like felt more powerful that way. And then that's okay, right? So there's a
Yeah.
bunch of different sort of considerations, but I do think the more people know about these options,
Yeah.
and correlated with like the recommendations and the evidence, they can trust their instincts a bit more. Because I've had so many times where clients have said, gosh, like I was in this position, I was doing great, and then like the nurse, like they made me go on my back, it felt so wrong.
Yeah.
And so, I think if people know the data and they know the biology, they know the mechanics, in a situation like that where the care provider's like, now do this, the assumption is, well, the care provider knows best. But in this instance, they can say, no, 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 I know best.
Mm.
And then they can
Yes.
question that. They can say, you know what? You're asking me now to go in a position that's going to make my pelvic outlet smaller. You're asking me to now go in a position that the guidelines said I should avoid. And they can say, you know what? What are our other options here? Because that's just not something I'm comfortable doing. So then they can kind of use
Mm.
their own voice.
And I think it's great as well. I would say always, doing as much homework as you can long before labor. So, and yeah, I know it's
Totally.
tricky within a public system sometimes because you don't know who you're going to see on the day. But even, talking to other moms who've gone to this particular hospital or worked with a provider so that you have an idea of what to expect. That
Hmm.
does this particular hospital, is everyone giving birth on their back, or is there, is that changing? And actually,
Yes.
seeking out the places of birth where physiology will be supported. And it's that idea of I just coming back to what you were saying about some women will choose to go on their back. I think is so important to hear. And I think because it is almost vilified, somebody will say, oh, that's the worst position ever, and somebody will always come in and say, you know what, it really worked for me. But
Hmm.
what I tend to see is for those women, it was definitely a choice that they had tried
Hmm.
some other things and
Hmm.
they found that this worked for them.
Hmm.
I think it's very different to, again, like as you said, someone who has been directed by a
Hmm.
provider that
Hmm.
is the position of choice in this particular facility. So,
Hmm.
but always, advocating for yourself, having a partner with you that can, because in
Hmm.
that moment, and I've seen it, myself when I've been to birth as a doula, where it's, mom is on all fours in a really comfortable position. She's starting to push, and the provider is not comfortable with, catching the baby in that position or mom pushing in that position. So mom has been, very clear, I want to be on all fours. And then it's, well, we can't really see what's going on, or, could you just turn over just for 1 minute? Well, just 1 minute, and then we'll make sure everything's okay. And then you can turn back over.
Hmm.
And I've seen time and time again, the minute she's on the back, it's like, okay, no, 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 this is much better. We can see everything now. This is the best position for you to be in, no matter how comfortable or uncomfortable mom is. So I think for the partner to be able to, because you're so vulnerable in
Hmm.
those moments, and the sensations you're experiencing, especially with the first baby, it can be quite alarming because this
Hmm.
huge pressure that you're feeling. So to try and advocate for yourself at that point is almost impossible. So having that birth partner who is competent and confident to facilitate for you for those position changes is so important, I think, for anyone who is preparing for birth. Make sure your partner is really well clued in on birth physiology and what your preferences are. And of course, in the event something out of left field happens, then absolutely, we trust our care providers. We've chosen this particular place of birth. In the event that if something came up, we have all of this expertise available to us. But I think, again, if all is well, if mom is well and baby is well, that position choice should absolutely be deferred to mom, and
Yes,
it really shouldn't be open for
absolutely.
discussion. And it is disappointing when we should expect our care providers to understand how the pelvis works and how the
Yeah.
pelvic floor works and how gravity works. So it's so disappointing, I think, when you see this repeated um, focus on mom in that lithotomy position, and knees pulled back and just making things, or open your legs more, this whole thing of make space for the baby. And I'm like, oh, if you just let mom tune into her own body, she'll actually, and
Totally.
I'm sure she'll actually bring her legs more closely together, and that
Right.
that provides that little bit more give in the tissues. But what's generally happening is someone is pushing the legs open, give
I know.
nice and wide for baby. Baby needs plenty of room, and it's like, stop.
For sure. And that's a big part, honestly, of again, like the education that a pelvic health physio would actually be providing. Even actually, I find when women come in for their internal exams, they're often like, okay, and like right away want to drop off their legs. And I'm saying, oh, no, 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 no. Like, I just need about this much
Mm,
room. I actually want you in neutral. I do not want you feeling vulnerable. I want you feeling safe. It's absolute rubbish and nonsense that that's helpful. It actually will stretch the tissue across the front, make it more uncomfortable,
Hmm.
and it narrows things inside. It's so not helpful. So I will actually even give that education, even just for an exam.
Yeah.
And the other point I just wanted to make to Tracy, before we're going to close off soon here, is yes, having that empowered partner, but that's also where I would argue that doulas can be brilliant because they can really give that partner confidence. Like the doula can't sort of dictate what's happening in that room in the hospital. They have to be really careful. They're doing a lot of
Yes.
their advocacy ahead of time. But if they've kind of really empowered that partner and they're there and the partner's there, they can kind of just look at them and like encourage them, like, yes, this is now your
Mm,
opportunity to advocate, for your partner
yeah.
here. And it's interesting. So I have a lot of clients who the reason why they come see me is I don't want to tear in my birth. I was told if I came to see you
Mm,
that I wouldn't tear in my birth. And I think the ones who see me in person are expecting me to do some magical internal technique that's going to give them this pelvic floor that they're going. And actually, one of the first things I'm saying is if you are really serious about minimizing tearing and having your pelvic floor come through this as optimally as it could, the best evidence is to get a doula. Really and truly. There are absolutely other things I'm going to do, but perineal massage or any type of manual work is like 1% of like utility compared to a doula being like
mm,
99% of the variance. Um, so that's another thing that I think is just so important because why does a doula work so well on every single outcome? Well, because they're helping that mama to have her own agency. And that's the point.
hmm.
She'll do so much better if she's leading the charge, right? And like a
Yes.
doula will help her do that. So yeah.
Yeah.
And help her partner
Yeah.
help her to do that. Yeah.
Yeah. I always say, well, I would never go into the system, the modern system without a doula.
Hmm.
Never. No matter how much I trusted my care provider, I
Yeah.
would just, it's that having that familiar, friendly face with you that you've hopefully gotten to know through a little bit of your pregnancy. And
Hmm.
then on the day, even if the doula is not saying much,
Hmm.
because again, depending on which kind of, doula philosophy you follow or whether the doula can be an advocate for you or not, but just the presence of the doula in the room, it does change behavior of
Hmm.
everybody in the room just
Hmm.
by that presence. And that it's almost really it's just sometimes it's just a look and the partner
Hmm.
knows, okay, yeah, I've got this,
Yes,
and it's for
exactly.
those little hints and little nudges of where the doula is never there to replace the partner, but just that presence of this knowledgeable, kind-hearted, supportive, friendly person in the room with you just
Hmm.
gives you that confidence to maybe push back a little bit or ask more questions or just remember to ask the questions, which because
Hmm.
there's plenty going on the day. But I would say, yeah, absolutely, a doula is just it's a no-brainer. And
Hmm.
no matter what kind of birth you're having, there's a place for doulas in cesarean birth as well. So there's just so
Totally.
many benefits to support. This is what we're talking about. We're talking about women in a very vulnerable, huge part of their lives where having as much, compassionate support around you is going to affect your mind. It's going to affect your emotions, and which will all affect then on how your body is coping with labor and your recovery
Hmm.
postpartum. So I think for any watching and listening out there, if you have an opportunity to find a doula and hire a doula, I would say, and I know sometimes finances can be an issue to, make it part of, a, baby gift, have a few
Hmm.
relatives chip in and instead of, getting the super duper stroller and
Hmm.
the crib that has all the bells and whistles, that invest in a doula. I don't think you could ever go wrong with
Yeah, I
giving
agree. And I
yourself that
think
support in such an important time in your life.
so important. And I think too, especially if people are very clued into, I want my pelvic floor to be okay. Because thankfully, pelvic health is a little bit more on the radar. If they understand your
Hmm.
best investment to that is actually a doula. Like the doula will do all these other things, but if really and truly you're wanting to be preventative with your pelvic floor, it's our most evidence-based choice for that, really and truly. So I think it's just another maybe motivator to get one, right?
Yes, absolutely. Sinead, thank you so much for joining me today. I know before we came on live, we have some lots more topics that we want to kind of dive into. For those of us who are maybe not who are past their baby days and midlife and looking at what should we be talking about when it comes to pelvic health. So I would love to chat to you again sometime
Hmm.
soon about for our older ladies that
Hmm.
would like to again learn from your amazing knowledge and expertise on this topic. But thank you again so much for joining me, and I hope everyone enjoyed it. And tell me where everyone can find you online, your social media, and we'll include them in the show notes as well. So where can everybody
Yeah.
find you today?
Absolutely. So, my Instagram page is much more of a professional page, so lots of kind of education and videos. So that's a good place to find me. And my handle is at Dr. Sinead, so Dr. Sinead. I also have a McMaster Experts page that kind of has all my research. So I'll make sure the link is there. My clinical practice is The Womb, The World of My Baby, www.thewomb.ca. So there's lots of great information there. But that's also where, if you were wanting a consultation with me virtually, if you don't live in Ontario in Canada, you could book with me through there. And then for healthcare providers, I do also teach some courses in pregnancy related pelvic girdle pain. I do that through a company called Reframe Rehab. So if you want to learn a little bit more about that, then I'll make sure that that link is there too. It's Reframe Rehab.
Right. Thank you again, Sinead.
Okay, thanks so much, Tracy. Bye, everybody.
Thank you. Bye bye.
Thank you so much for tuning in to today's episode. Remember, empowerment begins with knowledge. If you enjoyed our time together and want more content like this, don't forget to like, subscribe, and share with your friends. So stay inspired, stay informed, and until next time, take care of yourself.